Okay, so please scan the QR code here for the Mentimeter. Okay, everyone ready? Okay, so this is a warm-up question. How long have you been attending I-ELCAP conferences? Interesting. More than half or about half. It's the first I-ELCAP. Okay, interesting. Okay, so we'll go on to the actual cases, and this is a collection of cases that we had at the Hadassah MDT meetings. So I would like to now share your experience to see how we proceed with these cases. So first case, some of the cases I will show are incidental and some are from lung cancer screening. So this was a 40-year-old female who had recovered from a large cell lymphoma 8 years earlier. Her last PET CT was in 2017 and it showed complete remission. And then she went for a hematology checkup, and she had this finding on her chest CT. Okay, so this was April 3rd. And what would you recommend as the next step for this lesion? 1 month, 3 months, low dose CT, PET CT, biopsy, or surgery? Okay, so there is a majority here for immediate biopsy. Okay, so majority for a biopsy, but also a large number of people thought 3 months, low dose CT or PET CT. So what was actually done is a PET CT, her hematologist, like a reflex, sent her to do this PET CT. As you see, the SUV max was high, 7. So what would you recommend now? So now more people would go for biopsy, something immediate surgery. And then I would like to ask the panel members, what would you have done and why? So starting with Ella, what would you have done?
I think I would recommend they see our pulmonary medicine colleagues and do bronchoscopy. This is cavitary or frothy in the middle. So in a patient with a history of lymphoma, I'd be wondering not just about malignancy, but about a higher risk of atypical infection, particularly in the upper lobe. So I would send off to our pulmonary medicine colleagues, probably with a bronchoscopy lavage.
Okay, Matt?
I was leaning towards biopsy from the get-go, but if the patient is afraid of needles for some reason, we could always do a 3-month follow-up would be my next option. Hard to tell what it is, but I think I thought that PET wouldn't be useful because it's ground glass in the center, so maybe slow growing. I don't think PET would give an answer, but it looked like it was PET positive, which was even more concerning.
Okay.
There is a newly seen peripheric lesion, and I recommend biopsy, transthoracic biopsy, and SUV7 is not so specific, so it's probably can be lung lesion, maybe cancer also.
Okay.
It seems a bit like a reverse atoll. I think there's a broad differential diagnosis, and this is a patient maybe also, I don't know if it's still immunocompromised, I don't know. So broad differential, I would send to pulmonologist.
Okay. So I thought it was you know, 40-year-old woman, she has recovered from lymphoma. I was sure we scheduled the biopsy, but I said, let's do it in 1 month. Okay, and then this was what it looked like 1 month later. So what would you recommend now? Okay, so some of you are still willing. Oh, okay. So most people say biopsy or surgery. Okay, big majority for biopsy, which is indeed what we did. And what was the result? So it was a non-small cell lung cancer. She was scheduled for a lobectomy. And then it turned out that it was stage 4 lung cancer. So she already had the visceral pleural invasion as well as the lymphovascular invasion. So the question to the panel is, would you have thought that this could be disseminated lung cancer?
I guess I would say you never know. Even with the smallest cancers, they could be disseminated, or the largest cancers may not be. So
Right.
you never know.
So anyone else?
On the initial PET, I thought the lymph nodes maybe were positive already on the first PET scan.
No, they were not.
They were not.
No. It was not a lymph node invasion. She actually went to surgery, and when the surgeons opened the chest, they saw multiple nodules on the pleura. So it was not. No one thought it was going to be stage 4 lung cancer.
And how long was the entire interval between the first?
1 month.
1 month
One.
until surgery also.
Until surgery, maybe 6 weeks. So not very long, but very aggressive cancer, very strange looking young woman. It was really heartbreaking, I have to say. Okay, second case. This is a 70-year-old female with persistent cough. And this is a video of her CT scan. Okay, so I hope you got a good look. So what do you think is the likely diagnosis here? Is it infection, a cryptogenic organizing pneumonia, pneumonic type lung cancer, or that you can tell without prior imaging? So about half of you thinks that it's COP, more or less. Okay, we have previous chest X-rays. So the first one that I showed you was from, I believe, September 1st, and then we have here a chest X-rays from June and from July. And you can see that the left upper lobe opacity has improved, and maybe in the left lower lobe it's worsening. Okay, what would you recommend now as the next step? Is it 1 to 3 months low dose CT, PET CT, transbronchial biopsy, or transthoracic needle biopsy? Okay, so most people said follow up, but also almost 40% of you think transbronchial biopsy. So we did do transbronchial biopsies, and the biopsy showed what the pathologist described as highly suspicious for atypical adenomatous hyperplasia or pure lipidic growth pattern. With tiny foci of invasion, he could not rule out tiny foci of invasion. So what would you have done now? Okay, 1 to 3 months low dose CT, PET CT, transbronchial biopsy, or No, he's very good, and he's not part of the MDT, but we meet with him once a month, and he showed us the actual, and it did look to my non-pathologist eyes, it looked like lung cancer. Okay, so many of you think PET CT, the majority. What we actually did was a follow-up CT. And you can see that there are new lesions in the left lower lobe. Okay, so my questions to the panel, what do you think is the likely diagnosis? Do you think it's a mistake that it's lung cancer? What would you have done? What would you recommend?
Where was the sample from, the biopsy?
From the right lower lobe.
So that seems to be behaving differently than everything else, which is kind of waxing and waning, could be a confounding other diagnosis like organizing pneumonia, but that mass is still there.
Okay, so what would you do?
Back to my pulmonary medicine colleagues.
I think the PET CT might be useful to guide the biopsy. So you want to stick the needle in the hottest part of the lesion. Especially with these large
So we do have
consolidations.
one biopsy already. So you would repeat it? You would do transbronchial biopsy or just let the pathologist decide?
It would be CT guided, but directed towards the hottest site on PET CT.
Okay, so you think PET CT and then biopsy, and I see Rosemary agrees.
I think this case very challenging. First, I think about the pneumonia. So when after the follow-up, we see some changes, but it still saves some findings in the right lower lobe. So I think about the biopsy also.
From the right
Yeah,
lower
from-
lobe. Okay.
Yeah, I would also do first the PET CT and then a guided CT or bronchoscopy. Yeah, I mean, you could also do it probably a bronchoscopy guided biopsy, because you have to know if this is not multifocal, right?
Okay, so for this, I don't have a final result yet. It's an ongoing case. Okay, so cases 3 and 4. So this was a 77-year-old male with 30 PEC years, former smoker, and this was the baseline study. So there is, I don't know if you can recognize it, but it's a periphyseal nodule. It's slightly over 10 millimeters in diameter. So this was a baseline study. Okay, so it's not advancing for some reason. Okay, and these are the axial, coronal, and sagittal studies, so reconstructions. So what would you recommend as the next step? In this lesion, which is slightly over 10 millimeters in diameter. So the majority would like to do a 3 months low dose CT. Okay, great majorities, more than 70%. And this is another case, it was on the same day. A 63-year-old male with a new 4 millimeter periphyseal nodule in the right middle lobe. It's very small, as you can see, 4 millimeters. These are again the axial, coronal, and sagittal reconstructions. So what would you recommend as the next step here? So even though it's new, I see that many people would say 12 months, a time more or less between 12 and 6 months. Okay. So these are the questions to the panel. When do you start suspecting that the periphyseal or juxtapleural nodule is not necessarily benign? And what would you recommend for pleural attached nodules which are of the correct shape but larger than 10 millimeters or growing in size? I would just like, before we will go back to this, but just to mention this article by Dr. Zhu and David and Claudia about management of pleural attached nodules, which was published in Radiology earlier this year. And this is based on an older study by the HOOP with typical periphyseal nodules, atypical nodules, and non-periphyseal node, or the periphyseal nodules are unlikely. And this concept was also extended to any juxtapleural or a pleural attached nodule also in the periphery or a perimediastinal or on the diaphragmatic pleura. So let's go back to the question. Okay, so when do you suspect that a nodule? So I thought with the second nodule that I showed you that was new, many of you were comfortable just saying 12 months. Okay, Ella.
That one bothered me not as much, well, partly because it's new, but partly it looked like an atypical periphyseal nodule because it looked like it was bleeding along the pleural edge. It wasn't centered on the pleura at a fissure, and it looked like it was going along the fissure. So that part bothered me about that one. The other one, you know, if we use the 10 millimeter average size threshold, that's bigger than 10. So that by that definition, we don't have enough data on 10 to 20 millimeter periphyseal nodules to really say it's safe enough to follow.
So what would you have done?
Probably a short term, 6 months, 3 to 6 months CT, somewhere in that range. It's big enough that at 3 months you could see growth if it's going to grow.
So for the new nodule, because it's small, I find that I see those frequently in practice. And so they often come and go. Sometimes they're new, but then they're stable after that. And so I wouldn't necessarily be concerned with those, the new ones that are small, less than, for example, the almost 4 millimeter. But if it's larger, 10 millimeter, even if it's flat, I would be more concerned. I remember very well some cases that David Yankelevitz biopsy, they're flat like paper, but because they were 10 millimeter in diameter, it was biopsied and came back positive. I remember there was a case of breast cancer was positive. Another one with prostate cancer was positive. Again, they look flat like paper, but more than 10 millimeter in one of the diameters. So I would be more concerned with those.
For first big nodule, which size more than 10 millimeters, all features looks like typically periphyseal nodule. Yeah, the form, the shapes, the margins, and but the size is bigger than 10. So in this case, I recommend a short-term follow-up. And if the nodule is growing or showing some suspicious other features like changing the form or loss smooth margin, or we can see some speculations. Maybe I recommend next step PET-CT or biopsy. For the newly seen nodule 4 millimeters, I think it was baseline, yeah?
It was a baseline.
Yeah, for baseline.
No. The new was, it was new because we had the previous one. Yes.
The shape of those nodules looks like not so typical, a little bit rounded. And maybe if I zoom it, maybe margins, I can assess more better. So maybe a short-term follow-up firstly.
Okay.
For the large flat one, I doubt if it's cancer, but because of the size criterion we have, you'll have to do a follow-up, short-term follow-up. The other one, it's only 4 millimeters. So I think to find growth, you have to wait 6 months. Unless you do filometry, then you could probably figure it out in 3 months.
Okay, thank you. So let's go to the next case.
What was the answer? What happened to them?
No, they are new.
Oh,
I
no,
will
no,
tell you next time.
You'll have to tell us next year what happened.
Yes. Okay. So case number 5. This is a 59-year-old female smoker with COPD. And her previous study, as you can see here, was in March of 2022. This is a study from January of 2025. And she had a new 38 by 34 millimeter mass in the left lower lobe, as you can see here. So what would you recommend as the next step? Is it 1 to 3 months low dose CT, 6 months PET CT, CT guided biopsy, or bronchoscopy with TBB and BAL? So most of you would, okay. So now the majority are for bronchoscopy. Okay, but many people also thought CT guided biopsy and PET CT. Okay.
I just asked, why wouldn't you do PET CT first? Because if you found lymph nodes in the mediastinum, it might change where you do the biopsy, or if you found, given the size of it, and it looks kind of ugly, you might find something extrathoracic. So why go to a target biopsy with something that looks like it's got a high probability of malignancy and could have spread already?
Okay, but it was new, right? Also. Okay, so we did do a PET CT, SUV max of 7.1. Okay, so what would you do now? Now we have the
And no spread anywhere.
no spread, only this lesion. So what would you have done? So majority would say CT guided biopsy. Most of you. For the follow-up option, no one chose this. So CT guided biopsy, you say. But what we actually did was bronchoscopy, and this was a granulomatous caseating necrotizing pneumonia, and on BAL strep was recovered. Okay, and this is follow-up. I'm missing the date here, but this was recent. This was a follow-up study in September. So completely gone. But now we have a new case, a similar case with this finding. It's a 88-year-old non-smoker with productive cough. He had the COVID 1 month earlier, and now there is a 28 by 18 millimeter nodule in the right middle lobe. So this is what it looks like, and the coronal reconstruction as well. You can see here the previous study. So a year ago, so here I have the date in the Israeli way, but a year ago in August 2024, there was nothing there. Now it's new findings. So what would you recommend as the next step? 1 to 3 months low dose CT, 6 months PET CT, CT guided biopsy, or bronchoscopy? Okay. So it's a tie at this point. Okay. PET CT, most of you say PET CT. Okay, but what we actually did was a repeat CT. So the previous one, let's see, I don't remember the date. So previous one was in August. So 1 month later, more or less, we did a repeat CT. It's slightly increased in size. And there are new twin bud opacities in the right upper lobe, as you can see here, and also in the right middle lobe. Okay, so he did do a PET CT. Eventually, it was, I think, the day before I started traveling, and it was there was increased uptake, and they're requesting a needle biopsy. So maybe it was already done while I'm here. So what are the clues that, what do you think about this case for in the first, the later case? What clues are you looking for to differentiate malignant from benign? So we saw my case number 1 looked like possibly it was infectious, inflammatory, and it was lung cancer. Now we saw a case that resolved, so it was infection, and we have a second case. We don't know the diagnosis for it. And how long are you willing to wait before sampling a lesion when it's new, but it's suspicious looking? And if you want to do follow-up, how long are you willing to wait? Okay.
I think one thing we haven't yet mentioned about any of these cases is the discussion with the patient and the patient's values and what is important to them. We haven't heard a lot about what's going on with them symptom-wise. Are they having signs of new cough, sputum, have a little bit harder time breathing? Is there anything else going on from a clinical perspective? And without that knowledge, you're kind of looking at images in a vacuum and trying to make a decision based on sort of clinical algorithms that we don't have all the information for. So for example, if that patient with the tree and bud and that kind of new patchy stuff in a couple parts of the same lobe, it's all lobar. If they were having signs and symptoms of infection, cough, new sputum production, probably increase the chance it was probably infectious. They may treat them with antibiotics and then do another follow-up loaded CT if that's what the patient preference is. If the patient is very concerned about cancer, very anxious, they might want to go to a PET CT and potentially bronchoscopy biopsy. So I think there's a variable in here, which is the patient, and what's going on with them symptom-wise and what do they really want to do. It has to be included.
I'm not exactly sure about that case because in terms of size, if you think cancer, you go for PET CT directly. If you think it's infectious, you treat it as such, and then a month is maybe even a bit fast to do a repeat scan. So I'm not exactly sure what you were thinking here, because if you think cancer, you're not gonna, with this size, you're not gonna wait for another month and see, let's see what happens. I mean, right? So
yeah, I think we thought it was the infection, or at least some of us. I think there was a controversy, and even among the pulmonologists, and the one who is the direct pulmonologist of this patient, he wanted biopsy right away. But in the tumor board, they said maybe we should wait a little, especially with the new tree and bud opacities. But, sometimes it's, I'm sure it happens in your tumor boards as well. There is no agreement, but something has to be done.
patients don't come to the tumor board before they already have their PET CT, for example.
They don't
So
have to the tumor
they
board?
do. I mean, they first have their PET CT before they come to the tumor board. So, and preferably with a bronchoscopy and a biopsy already made.
Okay.
No.
Yeah, I agree with the shared decision-making approach. From the imaging standpoint, in the absence of air bronchograms, I think my suspicion for malignancy is higher. And if the patient asks me what should I do, then I would recommend probably tissue sampling. But if the patient wasn't so sure or was afraid of needles, then 3-month follow-up is another option. I find that, again, PET may not be so useful distinguishing infection from malignancy, because even if they're positive lymph nodes or negative lymph nodes, could still be a pneumonia. So I think shared decision-making is a good idea.
I think for patients with COPD, suspicious finding like nodal like mass or consolidations are common, and our patients heavy smoking also. So I think I recommend some follow-up, short-term follow-up, to have some time for this. When second patient looks like infection, yet to sometimes to after the treatment to take a look some changes. And I also think that PET CT it's not so helpful because if it's pneumonia and if it's cancer, in both cases, we can see FGG uptake. And for me, some clues for to differentiate it for benign findings is, of course, air bronchogram and Trin-Bad patterns like here.
But what happened here was that we did short-term follow-up, and then the lesion is a little bigger, but there were Trin-Bad opacities, so it was a little confusing. So anyway, I think he will have a biopsy, and also I will give you an update on this next time.
Maybe for case, which one of the case we noticed that it's rapidly growing. It's also looks like more infection, but cancer may be growing.
Very aggressive cancer.
Yeah, of course, it's very aggressive. It's very challenging.
Okay, so this is case number 6. So she was, so you see her history here is not relevant to the findings. 72-year-old female past smoker, and she has this part solid nodule. The overall size of the nodule is 16 by 11 millimeters, and it has a solid 4 millimeter, maybe something like a non-solid nodule adjacent to it, and it has been stable for 2 years. So you see it on the axial slices, coronal and sagittal slices. It's stable, completely stable. So what would you recommend for this nodule at this time point? 12 months, PET-CT, transthoracic needle biopsy, or surgery? Okay. So most of you, a big majority, thinks 12 months, low dose CT. Actually, the surgeon really wanted to operate on this, and it was already scheduled for surgery, but then the patient changed her mind. But so I would like to ask you, how long would you be willing to follow a stable part solid nodule, and do you think it should be managed differently than a non-solid nodule?
Annually for the rest of their life. And I say that with seriousness. You don't, it looks like a pulmonary adenocarcinoma. It's just a matter of, is it going to stay like that forever, or is it going to at some point decide it's going to change its behavior? Something happens with the patient's immune systems, they're on medications, they're diabetic. For, at some point, well, adenocarcinoma, even stable for 5 years, 7 years, all of a sudden could start growing. So I would say annually until this patient is no longer able to get or willing to get treated for it at some point.
So I would like to ask you and the other panel members. So if you think it's carcinoma, why not go right away for biopsy or surgery? Why follow it if it's,
Because not every cancer is necessarily going to hurt the patient that it's in. So there's the harm of taking it out and the potential complications, as low as they may be, as great as surgical risks, surgical complications have fallen. There is a reality. There are these patients who form part solid and ground glass nodules where you've taken out a cancer here today, and now another little thing over there, this little ground glass thing that maybe you didn't even see before now starts to grow. And then you cherry pick that one out at surgery, and then it comes in another, another lobe. And so you end up with patients having multiple, even if it's small, resections for cancer, one after the other. And so you have to think about lung preserving for their health and their ability to breathe and their activities of daily living. So just because you can doesn't mean you necessarily should. And we've got lots of examples of cancers in other body parts that taking them out doesn't necessarily extend a patient's life. But shared decision-making. Shared decision-making.
I agree 100% with the following it up forever. I also agree with the idea of preserving the lung, because I've seen, for example, atypical adenomatous hyperplasia look like this. It's not really a cancer, just metaplasia, and can look like this and be stable forever. I do have a question for the panel that's a follow-up. So if we do follow-up forever, should we scan every year? Because I hear sometimes you can maybe scan every 2 years if it's been stable for 8 years, for example.
So I'm reminded of some cases of patients who say they were being worked up for an organ transplant in some body part. And during that time, they found before they got to an organ transplant, they found a nodule. And they followed the nodule for 2 years. They're trying to use best practices, follow stability before deciding to put a person on a transplant list, whether it was lung transplant, liver transplant, renal transplant. And then they get immunosuppressed. And now all of a sudden, what was this 2, 3, 4, 5-year stable nodule does, this. It grows all of a sudden. So things happen. So I think you don't know when it's going to grow, and you don't want to miss the opportunity. I think if that started to grow 3 months after the last follow-up, waiting another 21 months is a long time.
In that situation, Ella, in our institution, they would take it out before the transplant, because the transplant surgeon would say, "Oh, this is a patient with cancer? Uh-huh." So they would want to know that this is a cancer-free patient, and know that before they do the transplant.
So if it was
Yeah.
cancer, would they let the patient be transplanted?
Yes, if it was completely taken out. I mean, then you
With
would
no
have,
like 3 or 5 years proving that it didn't spread? Interesting.
because then you know exactly what pathology it is, and it's an early adeno. We know that, right? It just, if there's no invasion, and you just give the certainty, okay, it's gone. But I do think that this is a matter of, like you said, discussing with the patient. And I think it also matters where that lesion is, because this could end up, not this particular one, but you could have this stable lesion and you could have with lobectomy, right? And that's not exactly what you would want to do in many patients.
Okay. So this is case number 7. So I think it will be the last case that I'm going to show, right? Because we're going to soon be out of time. A 28 by 13.5 millimeter fluid-filled cystic lesion obstructing a subsegmental bronchus in the left upper lobe. It has 2 small calcifications. You can see. Sorry. You can see one of them here, right? This one. And then a second calcification as well. And it was unchanged for, I believe, 3 months. Let's see. So this was July. And this was April. Okay, so cystic lesion obstructing a subsegmental bronchus. What would you recommend as the next step? So is it 6 months, 12 months, low dose CT, PET CT, bronchoscopy? And there is no need for further workup. So I'm reminding you, we already have 3 months and it's stable. Okay. So most of you feel comfortable waiting for a year. Okay. So have you ever seen a similar case, and what would you have recommended? Last question to the panel. What do you think?
I've seen some couple of similar cases, and some, if you see fluid-filled cystic lesions, in most cases, maybe it's bronchogenic cyst or mucoid infection, maybe. So after the short time follow-up, if it's still stable, I would recommend an annual repeat. So, and if it's still stable without wall thickening or newly seen maybe some solid components inside of the fluid-filled cystic lesion. So I'll continue to follow up.
Okay.
Is this not a fingering glove? I don't see it on the CT image itself, but is it not a dilated bronchus? Are you sure?
It's just this oval shaped. This is it. It's not like, it's not converging. It doesn't really look like fingering glove. So anyone has So our MDT here, our pulmonologists, they wanted to do PET CT and biopsy for this case. Sorry, PET CT and bronchoscopy. They were concerned about this, but the panel is not very concerned. Okay. So I believe this was I have another case, but we'll do it next time. Here? No, not yet.
Holland, great answers. Good to meet you.
Okay. So thank you, everyone. Thank you for the panel.